All right, good afternoon, everyone, and welcome to this month's Teach Educational Rounds. Here with us today, we have Dr. Peter Selby and Dr. Milan Khara, who will be presenting on our Vaping Q&A 3.0. And we're going to start off today with CAMH's land acknowledgement. CAMH is situated on lands that have been occupied by First Nations for millennia. Lands rich in civilizations with knowledge of medicine, architecture, technology, and extensive trade routes throughout the Americas. In 1860, the site of CAMH appeared in the Colonial Records Office of the British Crown as the council grounds of the Mississaugas of the New Credit, as they were known at the time. Today, Toronto is covered by the Toronto Purchase Treaty No. 13 of 1805 with the Mississaugas of the Credit. Toronto is now home to a vast diversity of First Nations, Inuit, and Métis who enrich this city. CAMH is committed to reconciliation. We will honor the land through programs and places that reflect and respect its heritage. We will embrace the healing traditions of the ancestors and weave them into our caring practices. We will create new relationships and partnerships with First Nations, Inuit, and Métis and share the land and protect it for future generations. So now we'll invite everyone to share which land you're joining us from today. And if you're unsure, I'll put a link in the chat in a second that you can use to find out. And while we're doing that, you're also welcome to share something you are currently doing to learn or improve your commitment to reconciliation. So I've just put the link in the chat. Feel free to see which land you're joining yourself from today and introduce yourselves in the chat. And in the meantime, I will just start sharing my own personal land acknowledgement. So my name is Rachel. I am a second-generation Canadian located on the lands of the Mississaugas of the Credit, which is covered by Toronto Purchase Treaty No. 13. And I continue to listen and learn about the stories and cultures of various Indigenous communities and ensure that their voices are heard. So I can see people have started to share, and that's great. And everyone's welcome to continue to do that. I'm just going to continue on with some more items in the meantime. So this is just a reminder that if you would like to receive a letter of completion for this Teach Educational Rounds, to make sure that you first have registered for this webinar and completed the pre-learning assessment, and as well that you have signed into this webinar using your full name, your first name, and your last name. And at the end of the webinar, we will send out a post-learning assessment and evaluation for you to complete within a 1-week period. So I'll continue on with introducing our presenters. First, we have Dr. Milan Khara. Dr. Milan Khara joined Vancouver Coastal Health in 2003, having previously worked as an addiction medicine consultant at CAMH. He's certified by American Society of Addiction Medicine, and his current work primarily focuses on treating tobacco use disorder and extends into other areas of tobacco control. Clinical commitments include leading the Vancouver General Hospital Smoking Cessation Clinic. Dr. Khara has also been involved in training healthcare professionals to treat tobacco use disorder, including supporting the Teach CAMH Teach project. More recently has been involved in initiatives to combat the rise in electronic cigarette use in high schools, speaking with legislators, educators, students, and parents. And he is also a clinical assistant professor at UBC. His research interests mainly focus on hard-to-treat populations and have been published in medical journals. Dr. Khara is also involved in many areas of tobacco control advocacy, including providing testimony in challenges to smoke-free legislation. And he has also appeared as an expert witness before the Standing Committee on Health to contribute to the development of a federal regulatory framework for electronic cigarettes. And here you can take a look at his disclosures. And our next presenter is Dr. Peter Selby. And Dr. Selby is a senior scientist and senior medical consultant at the Center for Addiction and Mental Health. He is a vice chair research and Giblon professor in family medicine at UFT. And his research focuses on innovative methods to understand and treat addictive behaviors and comorbidities. He uses technology to combine clinical medicine and public health methods to scale up and test interventions. and his cohort of over 400 treated smokers in Ontario is an example of this. He has received grant funding totaling over $100 million from CIHR, NIH, and Ministry of Health, and has published over 200 peer-reviewed publications. His research program of research utilizes a learning health systems approach to investigate how technology, equitable collaborative care can enhance the delivery of evidence-based interventions to the patient while also providing a more satisfying experience of care for patients and providers across systems. And here are his disclosures as well. And this is just to let you know that all Teach Educational Rounds presenters are offered honorarium, and presentation content is not affected by acceptance of this honorarium. And the content of Teach Educational Rounds are centered on evidence-based guidelines from the following sources. These materials and their verbal presentation and general discussion represent only general principles and do not remove the need for clinical assessments or treatment plans by healthcare providers. And with that, I will leave it to Dr. Selby and Dr. Khara to take it away with the presentation. Thank you.
Thank you so much, Rachel. Welcome, everybody. Welcome, Milan. Good to see you again. And thanks, everybody, for all that question. So how we're going to do this is we're going to play a bit of tag team in this hour, which will go by really quickly. So maybe we'll just go to the next slide. We'll jump into it and keep the conversation going. So Rachel, can I move the slides? I can't see the little thing to move it, but let me try. I can actually. There we go.
Perfect.
So we're going to take a look at the current state of evidence around vaping. We'll look at the dual use with cigarettes and potential vaping cessation interventions. I think these are really interesting topics. Again, it is hot, and we do need to start thinking about how we approach these issues for those who find themselves wanting to use ends, or those who want to quit. So here's the big one. A theme that emerged is they want to quantify how much people are vaping and what is the nicotine equivalent. So these are the questions. How do you figure out how much they're using? If they're saying I'm vaping X number of times a day, but really they don't know, and how do you calculate how much nicotine is in the various vaping products? What is the suggested nicotine equivalent? So let's walk through that. And there's some people have differing opinions about this, and we can each talk about how we approach these as we go along. So first thing I think is direct equivalence to cigarettes is not accurate, because the way it comes, various factors will influence that. Because what kind of device are they using? Salts? Are they using regular nicotine in there? What's happening? Are they naive or experienced users? And we also need to pay attention that even though that cartridge might contain 2 ml of nicotine at 5% or 20 milligrams per mil max, you don't know how much of that gets aerosolized, and you don't know how much of that gets delivered into the lungs and how much of that gets absorbed. So because it can be variable from just that whole conversion to the aerosol, but how the person puffs at it, and we don't know what the effects of flavors are necessarily on the absorption, and it can vary. So although places like Stanford have put out this, well, 1 pack of cigarette contains 22 milligrams of nicotine, they've said that is, and it's actually not factually correct. The amount of nicotine is about 20 cigarettes. That's not actually correct. That's how much how much is absorbed, because people absorb about 1 milligram from a cigarette. But the actual amount of cigarette in nicotine in a cigarette is anywhere from 3 to 5 milligrams per cigarette. So that's not, you can't do that. And so when you see what they've done to, nicotine in Juul pods, and of course we don't have these anymore in Canada unless they come illicitly, you can make that conversion. because if you look at some of the data, one of the studies shows that at best people are absorbing about 50% of nicotine. So I think even Stanford's got it wrong, and I think we have to be a little careful. But let me turn it over to you, Milan, as to how you what do you make of this, and then we'll talk about how we calculate.
Yeah, thanks, Peter. And it is interesting that this is a very common theme that comes up, right? People are clearly struggling with how to initiate treatment, and the first stumbling block is, well, how much nicotine is my patient consuming with their e-cigarettes? And I have to say, I'm kind of with you on this, and I've got a bit of a nihilistic approach. I think this is worthless. And as much as I also take a careful history around what product is being used and how often people are puffing and, et cetera, all the kind of standard baseline stuff that we collect, I then tend to really focus on titrating treatment to effect. So I don't think these concepts are particularly helpful. I think they may be giving us a kind of a crude determination as to whether somebody is a heavy, medium, or light nicotine consumer, but not much else. And I think these kinds of careful attempts to calculate nicotine absorption are kind of pointless. And not least because of what you said, transfer efficiency, right? I mean, we're comparing literally apples and oranges. I mean, are we going to compare the way that smoke penetrates the alveolus with the way that aerosol does? Even that is a kind of a bit of an unknown. So I think I'm with you. And what do you think?
Yeah.
Are you essentially using titration to effect as your main mechanism, or are you spending time with this?
No, I don't actually, and I go back to this that of course, if somebody says that they're vaping all day long, they're going through 2 ml in less than in 24 hours, and they wake up at night and they can describe to me their nicotine withdrawal, then yeah, I know they're tolerant. So then I'll be a bit more comfortable giving them a long-acting nicotine. But if somebody tells me that they're doing 3 to 5 puffs here and there, and and that cartridge is lasting weeks, then I'm saying, wait, that's not likely. But even, I mean, the good thing is that when you transition to the patch, and if we're saying people are getting absorption through the lungs with this, you have a lot of room in terms of even the calculation not right, because we know a patch roughly replaces the amount of nicotine in a pack of cigarettes. So if I've got good sort of history that this person is nicotine dependent, and you can tell that they have withdrawal, they miss, and those kinds of things, then I'm more comfortable. But really, it is a titration to effect kind of way, sort of approach. And in the link, I just in the chat, I just put a link to a paper by Judith Prochaska and Neil Benowitz. And if you go down in there to table 1, you'll see that a cigarette has an average of 13 point, each cigarette in what has 13.5 milligrams and ranging from 11.9 to 14.5. So, you multiply by that by 20, you're getting a lot more nicotine. It's getting closer to somewhere in between those Juul pods and Vuse pods to what an ELF pod has, right? If you multiply it. So I think this is a little bit misleading here that they put this out. And I think that's a big mistake, common mistake what people make. So let's go on. So I think this is how people try to calculate the dose, and I put this out there, the concentration of the liquid and the volume used daily to estimate daily nicotine delivered, maybe, but it's not how much is absorbed. So I will, if somebody's asking me to use this, I'll basically divide it by half of all this to get a sense of actually how much might be absorbed. But again, these are all things I think make us feel better that we're doing a calculation, but really, I don't think we have it there because there's such variability in devices. So people said, how do you assess? And when I looked at this publication, this seems pretty much everything. We ask about their vaping, what substance they vape, brand, and are they using? And the other question I'll ask now is disposables, because I don't think this had disposable. Disposables are the most commonly one, and yes, young people are using them, and they come sometimes in, 2,500 puffs or 3,000 puffs or 5,000 puffs. So you can get a sense of how long it's taking somebody to go through that, and that's how I do my calculations to figure out roughly how many puffs they're using a day. I know it's not how much they absorb, but how many puffs. And then the other one I ask about that is obviously flavors are important there, and the reason for using a disposable. I find that some of our elderly patients find that a lot more easy than trying to fiddle around, trying to change cartridges and things like that. So essentially that's where we find. I I don't know anything else that you ask about. In terms of the symptoms, I also ask about whether they have any nosebleeds and how dry their mouths are, because especially if they're using, more traditional vaping devices that has a lot more propylene glycol and vegetable glycerin, and they really complain of a dry mouth, dry nose, maybe a nosebleed because they're trying to exhale through their nose, those kinds of things. And then my pattern of use, I always try to find out if they have become grazers, which means they're just taking puffs through the day. And because, indoor vaping laws are kind of variable, they can hide and do it. I have patients who sort of vape indoor at all times. So I ask about that as well. What about you?
Yeah, very, very similar. Collecting most of this information that you see from this publication. Clearly, we've just replicated or tried to replicate what we do in a good tobacco use history, right? I'm also interested when I see kids as to whether they're getting this head rush thing and whether they're falling over. I've seen a few kids recently who have sustained lacerations, from hitting the sink when they go down after drawing hard on their vaping device.
Yeah.
But yeah, and the grazing. I mean, I'm certainly interested
Yeah.
in the kids who are puffing
Yeah.
puffing all day long from inside their sleeve. Pretty common.
And have you noticed that some people don't recognize they're getting actually nicotine toxic because they don't have any cues as to when they should be done. They just keep going and then like complain of being nauseous and lightheaded, even though they haven't got that big hit, because they haven't, but they've just been cumulatively going through the day puffing away, and then they are feeling sick. Have you seen that? And
Yeah, maybe I'm not asking the right questions, but I haven't picked up people becoming toxic, but I suspect that might be because I'm maybe not pursuing that. Is that something you've seen pretty commonly in kids?
not very common. It's sometimes, I mean, they tend to titrate back down and say, I think I did too much and I got kind of sick and I had a headache and I was feeling nauseous and things like that. And, I haven't yet had anybody who said, like, frankly, I threw up. No, I haven't had that.
Right.
But I've had that kind of, I think I've done too much vape. Okay, so these are the sort of things that we should be covering. And as you said, it's like a good history. All right, and I see Leslie is going back to uh, the dosing. She seems like it's doing a combination of what we're doing, calculate it out, and then reduce it by half, and then titrate to effect. So I guess we're all taking a more cautious approach to this and doing it. And then there's what should we assess as systemic symptoms? I think it's this, nosebleeds, cough, uh, any kind of hiccups and those kinds of things, because, if they're swallowing the nicotine, they're going to start getting hiccups, nauseous, reflux, etc. The systemic systems, I mean, typically, if you got too much nicotine, you're getting kind of a low heart rate and you're feeling weak, and you just kind of feel like blah. So those would be kind of the systemic symptoms that we would be thinking about. Um, you know, um, yeah, and I think everything else is pretty much self-explanatory. So we'll go on. What do we have? All right. So now again, I think everybody wants to come back to the same kind of thing. It speaks a little bit about the dosing and how do you calculate NRT. We covered that a little bit, but what is the NRT dosing? And we've just said, look, sort of played by ear. Again, nicotine, equivalence is problem, and people want to know the evidence. So, bottom line, minimal evidence for nicotine NRT to support effective vaping cessation interventions and for dual use cessation interventions. And we talked about the formula not being reliable. But also, I think we have to be really humble here, because in underage individuals who are using this, even in smoking cessation, like pharmacotherapy has had no either negative or mixed results. So whatever we are using here, everything is off-label, really, right? Any comments from your end, Milan, as you look at this?
Yeah, I mean, you know, that's an important point to make, that this is all largely a whistle in the dark, right? I mean, we're outside of evidence when we use NRT for these young people who vape. Now, whether it's working or not, it certainly the sense is that it is helping some of these mainly young people, and I think it's the right thing for us to do. But yeah, we're outside of evidence. But I have a question for you, Peter. I sometimes worry that I'm a little too cautious. I almost always start with short acting NRT, and then we'll transition to long acting when I hear that someone is using a lot of short acting. I also lose a fair few people who just don't come back, which I assume is due to the fact that they're young and ambivalence is pretty common in this population. But I do occasionally wonder whether I'm just underdosing due to my own caution and therefore not engaging this potential treatment population. Do you have any thoughts on that?
I mean, there is a risk of that. I think how I sort of handle that with people is give them a lot of ad lib, PRN, short acting, and say, okay, at least in that first off, let's see how much you're going to, and then let's see what we can do here, right? If we need to then switch over. I mean, I do this with smoking as well. I really try to move people, help them move to a passive 24-hour dose where they don't need breakthrough, right? Because then I know that person is fully comfortable. They have much better confidence of breaking the sensory and the motor aspects of the habituated part of the behavior. So I tend to, and if I'm not certain, I'll give the combination, give them a lot of short acting. In fact, this morning I just saw somebody who, in her late 80s, post lung cancer, and we put on the patch, and then she was short acting, and then follow up was using, like 15 pieces a day, not smoking, but then we had to up the patches. So I'm always moving away that. So I do the same thing with vaping. If I've hit wrong with that dosing, and they're using a lot of short acting to catch up, or they're vaping on top, and then I'll bump up the patch. So I don't think it's necessarily bad to start with a slightly underdosing, because you're titrating to effect, you're doing a gradual quit, and even if they stop abruptly, you've got enough short acting. So I put in the chat, Karen asked about what are tricks, and there's a whole lots of YouTube videos. We don't endorse them, but people do them, and it can be some of the subculture. Not everybody does that, but it can be some of the culture. None of the patients who come through our clinic who are older, none of them do tricks. It tends to be more hipster, younger people tending to do this, not generally a treatment-seeking population. So I think let's go to the next question. There was a question from Sophia, and welcome, Sophia. Sophia works at CAMH as well. Which is faster absorbing effect, smoking or vaping? And smoking, certainly. So nothing has beaten smoking. Obviously pod-based systems come close, but they don't necessarily reach that peak as quickly and as fast as you can get by combustion. But vaping gets pretty close. Any other comments on that, Milan?
Yeah, I mean, that's a good point, that we do seem to have found that what some described as the Holy Grail, right, which was a cigarette-like delivery,
Yeah.
maybe not quite there, but a cigarette-like delivery without the harm. And we can debate, what the degree of harm is, but clearly the modern vaping device is as close to a cigarette as we imagine we might get, right, in terms of
Yeah.
delivery mechanics. I do like those graphs that show the delivery of the early generations of vaping devices, where it's kind of bumping along on the horizontal axis and nothing is happening really, and not surprisingly, nobody was interested in those devices. But creating a cigarette-like delivery system is clearly what's made them attractive to youth, but it's also what gives us a potential treatment option for those who are looking for something that will replicate their cigarette and keep them relatively free of discomfort when they're trying to quit. So
Yeah.
fascinating stuff, really.
No, exactly. I think I think we have that for nicotine in the Teach course. I'm sure somebody we can pull it up, maybe Rachel at some point, or share it. But here's the thing that I like to see is we're trying not to replicate the level of addiction. We're trying to help minimize it as opposed to increase it or worsen it. So we certainly want to reduce the exposure, and certainly you could take a look at Project Vector for that kind of the data and the evidence to switching over and how to help people safely use vaping products. But I think the next question that we have in the chat is also very interesting, is from Daniel Deputer, is have you made NRT recommendations to any patients who primarily use nicotine pouches? Have you?
I have not. This is a population that I'm not seeing yet. I'm reading about it, but I'm not seeing it. What about you guys in
No,
Toronto? Are you seeing them in the clinical setting?
no, I have. I mean, here's my take on it, is that nicotine, if they so there are two things. So one is if they're using illicit nicotine pouches from the States, that's one thing, because that have 12 and 26 and 15 milligrams per pouch, which is really will make you quite sick if you're not tolerant. But again, I'm not clear whether those are the dose delivered or the total amount of nicotine in it. It's not clear. But the legal pouches, so that are available in Canada, authorized for sale as cessation aids, are really, if you actually look at the list of ingredients, I did a comparison. The list of ingredients in a nicotine pouch that is authorized for sale in Canada for cessation, compare the list of ingredients to how much a nicotine gum or lozenge has. It has fewer ingredients. I'll say that again. It has fewer ingredients than any of the other short-acting NRT that we have there. The downside of it is it's stained by the fact that it is manufactured by a company owned by a tobacco company. But as a concept, as a construct, in Canada at least, the 2 and 4 milligram nicotine pouches have a total fewer ingredients than any of that. And here's where I see its potential role is, one, if somebody has dentures, they can't chew gum. I mean, today, in fact, that patient was chewing gum and it was sticking to the dentures. We had to switch over to the lozenge. And for some, the lozenge, they land up chewing and swallowing. So a pouch, if they're willing, might be a relatively better option for some. But I think this is where we need to get the clarity. And if this was actually not manufactured by a tobacco company, then clearly, it would have been a nice addition to our options. And now, as you know, it's at least in Ontario, and I think in BC as well, it's going to move behind the counter. So from a harm reducing perspective, it is probably and likely, and not probably, it is likely, it is more safe than a vaping device. right? Because it does not have any respiratory exposure.
Which begs the question, Peter. I mean, I am sure that for a few years now, there has been a small, select group of individuals who are either failing, in inverted commas, with traditional smoking cessation aids,
Mhm.
whom you will eventually say, have you considered vaping? I'm sure you've been doing
Oh
that
yeah,
for a
that's
while.
part of our guidance. Yeah.
Right. So, classic harm reduction, and we're all doing it with a select population. So my question is, have you yet recommended nicotine pouches as a cessation aid for any of your patients?
I have, because I've had people who've said, they've done everything else, and before we go, uh, the issue now is that, they have to go talk to the pharmacist and get it. So yeah, there's a bit of education there, but again, and that's certainly not something we provide through Stop, and I don't think we can, just because of the way things are regulated. But I think it is an option out there. It's just too bad that it's owned by a tobacco company, and it's just that's the downside of it. But other than that,
So we can make the argument, you think, that for those folks who we were saying, look, have you considered vaping? We should be saying, look, have you considered nicotine pouches before that?
I mean, I think I do talk to that to patients in that way. I said, look, here's the thing from a lung perspective and a total nicotine perspective, this is it. But some people don't like the fact that they have a pouch and then they have to spit it out, right? Some people are really grossed out by that. So it's really a patient choice here. But I think we have to tell them, I don't recommend a brand, just like I don't recommend a brand of vaping device, but a lot of people go and buy Views, which is a tobacco industry product, right? So I can't recommend anything, but here is a bit of an ethical dilemma, right? Because this is potentially an option that has one brand. You want to make sure people don't get illicit pouches that have come over the border. But then, so the best way for me to do is to say, go talk to your pharmacist and maybe get it from them. All right, moving along to this. Here's this. I think we've talked about this about NRT use, so I'm not going to spend too much time on this. Just stick a quick look. I think this is pretty standard. Start low, go up. I think we've talked about this. So let's move ahead, because I know that we're about a half an hour in. So anything you want to say about this, or shall we move on?
Let's keep going, Peter.
Yeah, okay. So here's a paper by Ben Toll and others. They looked 30 adult e-cigarette users. It was a qualitative interviews, and then were randomized to got patches and lozenges and a booklet or the quit line. And 50% were dual users. 50% were mono vapors, and 26% were former smokers. So I'm a little concerned that they were giving. Yeah. So there were former smokers who were using vaping devices, and obviously these are the reasons why they want to quit. The patch use group quit for about 10 days, lozenges 6 days, adverse events about 2.5 days, and again, the people that got NRT seemed to quit versus the control group. So seems to work. But really need to think about that this is a preliminary data, so there's a lot of uncertainty. Can't, you know, um, uh, it needs to be replicated. Any thoughts about this?
Yeah, I mean, these are great though, aren't they? These early small studies which are sort of starting to back up the clinical consensus that's been driving what we've been doing for a few years, and this is what we expect to see. But we need to see bigger RCTs, right, that support these principles.
Exactly. But it's a good first start. I think it's a good, well done. I know the group really, solid researchers. So, now here's a good question. We have everywhere in the uncle is saying, oh, nicotine affects brain development. That's why we have to ban vaping and get rid of flavors and get rid of nicotine pouches. And you saw that in all the things. And the question is, how does this translate in the use of NRT for vaping cessation with youth? Is that why practitioners are hesitant, and what as public health professionals should we recommend? So your thoughts as we go through that.
Yeah, I mean, to the question about why there may be a reluctance to offer NRT to youth, I think it's more that we're just outside of evidence, and people are unsure, and this lack of equivalence tables is kind of making dosing difficult. So I think these are the grey areas that lead to the reluctance. Um, the animal studies that have driven some of these well-held beliefs about brain development and kind of problematic, but we just have to keep them in perspective. And if the choice is giving somebody NRT who's vaping, it's a bit of a no-brainer, right? We need to be getting NRT to these kids if they need help to quit.
Yeah. I agree with you. I mean, first of all, the animal model of nicotine on the brain is there. Absolutely. It's a you can see that in animal, but in human, what does that actually translate into? I mean, are we saying that the billions of people who smoked in the, heavily from the, early part of the 20th century to now somehow all have lost brain cells and development and are all superbly concentrated in places of, unable to work, unable to participate in the knowledge economy, are completely, brain damaged individuals running around? Are we saying that? Because, people have had long, early onset smoking in their, teen years. At one point it was like 9 or 10 when people started smoking. So are we saying all those people during those development ages have had brain damage to the extent that they're not functioning members of society, or have somehow lost out, and had they not smoked would be, superb contributors to the rest of the world somehow? Like, it's just not translating for me into what that is, as, and I think this is the problem, if we, as scientists, if we start raising all these flags without good, solid science behind it, it's one thing for advocates to do that, but it's another thing for scientists to be complicit, in that. So I think we do need to take a look at the evidence. But to come to this issue about the youth, at the end of the day, you've got to figure out if they're dependent. I think if they're using a lot and they're dependent, and we can get them exposed to a non-nicotine option, like what Leslie is saying, varenicline or bupropion, then yeah, sure, that's, but all of those are off-label as well. But whatever we're going to do is short term. So if we're going to give them short-term access to nicotine replacement, then that's fine. But again, if you've got a youth with complicated medical histories, early onset substance use, mental illness like attention deficit, externalizing behaviors, conduct disorder, depression, multiple suicide attempts, I'm not worried about the nicotine there, because they're already on a whole bunch of other meds. But if I can get them at least stabilized on nicotine, I'm quite happy to do that. And I think all of us should be, because at the end of the day, the in and out of nicotine in short-acting formats are more problematic to their mental functioning than a sustained low-dose exposure. So I think, yeah, as a general rule, you don't want a developing brain to be exposed to anything. But looking at the amount of exposure people are having to cannabis, I think we need to be mindful that we're not saying, oh yeah, it's okay to expose young brains to cannabis, THC, and CBD, and all the other chemicals that there are in a joint, or it could be in a edible, an extract at high dose, including vaping that they can buy at the cannabis store, with 98% THCA, and that's okay to vape. But oh, please don't vape nicotine. I think we need to be a little bit more consistent and realistic with what is going to impair this young person. and how do you help them lead a healthier life without substances, but to be pragmatic about it. Okay, I think there's also one in the chat. I think I put Nicole put something about flavors, and exactly the impact of flavoring on lung health is the most common one we know about is popcorn lung, which is through diacetyl in there, and that is something that I think mostly is not available, but we don't know because you don't have good labeling. But I'm looking at this article in terms of other flavors. I think we have to take a look at it. Again, if you put upon these studies that are done in vitro versus in vivo, you also have to look at that. So if I take a look at this, I can't tell whether this was a whether this was an in vivo study, but yeah, acute exposure to e-cigarette vapors, but I can't tell. Can you tell?
So I'm not sure what you're looking at, Peter.
Oh, this link that Nicole put in there.
Oh, right.
But I think because they don't say what their methods were. Maybe I'm missing it. So maybe I don't know if they did it in humans or. Yeah. I don't know what the method was. But anyway, regardless of it, I think we have to take a look at these things, and clearly this is where we just wouldn't. Right, I need to review this paper in more detail. But yeah, at the end of the day, it's not that we should be promoting vaping devices to youth, especially because they have an absolute risk of harm. But clearly, if they are dependent, then you got to help them with something. One of the things, I don't know if you do this, but I actually do start with asking people to try to quit on their own without anything. Or have they tried, and how long can they go? Because we know that young people, if they do try, what do they lose? One is that they'll learn that they can actually quit, and that there's nothing, just behavioral interventions work, or they're going to not work, and then we can think about whether pharmacotherapy is needed. But at the end of the day, we really got to think about what it is that we're trying to get them, to help them with. So I actually like to get people to try on their own with behavioral support, set a quit date, get rid of the paraphernalia, just a simple problem-solving approach. Educate them about the nicotine withdrawal, what that looks like, what they can do instead of it, and reassure them that it will pass. And if they can tolerate and make it, great. But if they can't, then come back and let's try some pharmacotherapy.
So would you do that routinely with somebody who presents who's compulsively vaping? Have a trial run at a non-pharmacologically supported cessation attempt? Would you do that routinely, or is that
not routinely? Because I mean, the other thing is, don't forget, we see a skewed population of people who have all sorts of other things, and they are heavily dependent or have tried already before they come to us. So yeah, I think if you've got somebody now you've never tried anything, give it a go. What's there to lose, right? But I think if you've got people with other complexity, other meds, other mental health issues, other substance use disorders, then they find it really hard to do that. But if I can just turn to this paper by a colleague from OTRU and at CAMH, Dr. Michael Chaden and Rob Schwartz and Jolene and Siddharth, they have this vaping dependence cohort study with about close to 2,300 Canadian youth. This is survey-based questions focused on willingness to use NRT, past use, and impact on quitting. In this cohort, 78% want to quit vaping. Almost 60% were interested in using NRT if it was available for free. But look at them, about 16% have tried, and about 12% said it helped them quit. So, of course, it's there, and so we need to really think about it. But this will all be off-label. But I think people are beginning to realize that if they do have had that issue of vaping, there's a subset that don't want to become lifelong vapors, young people. That's what I take of this, and that a proportion of them do want to quit, and a large number. Now, of course, this is not necessarily a representative sample of all vapors out there, but certainly this is quite a good large sample size. So I would take it that we do have youth and young adults who do want to quit. Any comments from you?
Yeah, interesting stuff. But Peter, I'm kind of as time presses on us, I'm wondering about the question of oral cessation meds, and I think we've got a couple of papers coming up in this next
let's
couple of
jump
slides.
over them. Yeah.
Yeah, be good to see that.
So here's the ones: the cytosine, bupropion, and varenicline.
Yeah.
Cytosine, if any of you attended Dr. Agadi's presentation about, in the US, they call it cytisinicline, that seemed to help with vaping cessation. And here you'd have to get the cytosine, which is a 1.5 milligram capsule, and then double up, so it gets kind of expensive, but it's there. But again, I think in the study there, it was, obviously over 18. Bupropion, nothing, and varenicline, same kind of dose, standard doses, seems to work.
Do you have much experience yourself, Peter?
Yeah, I've been using varenicline, but again, yeah, it seems to do the trick. But I haven't that many people. Like, I mean, most of the people who come are dual users. The single-use vaping tend to be the younger patient population.
Right. Yeah, I've had a few adults who are vaping, who have benefited from varenicline, but haven't used it on with youth.
Yeah. Okay. Yeah. All right, let's go. Preventing vaping. I mean, youth are pretty much price sensitive, and so really helping that. The availability is a big deal around uptake to prevent. The industry always likes education because education rarely does much. We all do education, but it's not sufficient. And that's why everybody can get behind it. Well, we should educate people. Well, you can, but it doesn't necessarily lead to the outcomes. But availability, either through density of outlets, where it's sold, age restrictions, price, all of those are big determinants of whether youth will pick things up or not. And I think there are programs like Not an Experiment out of the Selby Muskoka District Health Unit, and there are those kinds of programs, school-based programs that are emerged and have been evaluated and are scaling up to look at prevention as there. And there's something called Preventure as well, which might have some benefit for preventing. Typically for school age populations.
So Peter, the ultimate prevention intervention, of course, is removing a product from circulation. And I'm sure most of those listening will know that the UK, I think by next summer, is removing disposable devices.
Yeah.
Any thoughts on that as an intervention? Any thoughts on whether
I think, young people will certainly benefit, by not having these easy to use products. But on the other hand, we're starting to do some work with people with cognitive impairments and dementia and what have you, and they've been through everything else and they still smoke and can't get into nursing homes and stuff like that, or retire, so I think for that small population segment, we're gonna, or people with disabilities who are unable to have the ability to, refill things and do it themselves, then, dispose of, is not having disposal a problem. But of course, I'm also pretty cognizant that disposable cause a lot of litter, and there is no place, and we don't have a mechanism to, retrieve all the lithium and batteries in those places or dispose them appropriately. So I think there's a net benefit by not having disposal right now for all these reasons. But if there needs to be a way for, regardless of these, the disposal of these things to be managed better, and we're just writing a paper on that, and hopefully it'll be out soon.
Yeah, and
But
I
here's
think
the vaping prevention scoping review. You may want to take a look at it. We'll go, just interest of time, we're going to go beyond. And advertisements, increase awareness, and but again, remember, all of this is countered, I think, by what's people and young people are seeing on TikTok and other social media, unsupervised, outside the purview of public health and families or anybody. Again, here are some of the papers. Again, the Cochrane Review, no published RCTs of interventions to prevent or reduce e-cigarettes. And there are 22 ongoing studies. So TBD, if there's going to be something that will help. Quit vaping, teenagers stop vaping. We've talked a little bit about that. Punitive approach, we never recommend that, but a behavioral approach. And so I think behavioral approach means there is structure, there are expectations or rules, but it's not punitive. So we go by using a patient-centered approach, and I think all of us do this. We assess the severity of dependence, and we talked about that. Co-develop a treatment plan, and then manage and prevent relapse. That's how we do it for anything else. I don't know, anything you want to talk about this one with the youth? It's really family intervention, behavioral, but again, the evidence is pretty slim. Okay, moving on. We've talked about this. Regulatory issues are really the way. Parent involvement, and we talked about in education at schools, and of course we promote Quash the Crave and other apps. But again, they're no worse off than the booklets, but there is evidence that it's there, and it gets the conversation going. But really, I don't know about you, but when I look at a young person who's vaping and is unable to quit, I'm looking for what else is going on with this young person. There's typically, it's either going to predict other substance use going on, or it's going to be an emerging mental health condition or an undiagnosed mental health condition there. So it's like, there's something going on. So it's really, how do you keep that young person in the immediate? The long-term effects of the nicotine have to be considered with what else is going on with this young person. Are they using heroin? Are they using, street fentanyl? Like, those are immediate things that could kill them. So, or where's the cannabis use? Are they getting psychotic? Like, where are all? You've got to take a good developmental and psychiatric and mental and physical history to see where does quitting vaping fit into all of this. And you need to sequence it, because again, adults have great difficulty doing more than one thing at a time. Young people certainly, will find it. So I certainly, don't push. What about you, Milan?
Yeah, I mean, I couldn't agree more about the kinds of young people who are getting to our clinic. Often are complex and often have multiple problems. I assume there is a large population of young people who are much less complex out there who are vaping and who are stopping themselves or going through the whole kind of trajectory of their vaping use, but most of those who present to the clinic have multiple issues and need to be managed with care and with comprehensive assessments and often with multidisciplinary teams. And vaping is kind of just one of the long list of problems that we're looking at. And you've heard me say this before, Peter. I still worry that we don't really know what the trajectory of this population actually is. Are these kids going to end up vaping in the long term, or are many of them just going to go off into the next phase of their lives and stop spontaneously? I feel like we still don't really understand this population the way that we understand the tobacco using population.
Oh yeah, I think there's a lot to be learned about whether this trajectory will be the same or not. Okay, let's go. How are we doing for slide time? All right, these are all the interventions. We're not going to go over each one. These are all the ones that are out there, including the Quash app. These slides will be with you. You can all take a look at all of them and figure out which ones are going to work for your client. And last but not least, vaping as a cessation tool. Certainly take a look at Project Vector. This is the Cochrane review that shows that e-cigarettes, I think, are better than NRT in this situation. And clearly, you'll get 4 additional critters per 100 people you use this in compared to giving it to NRT. Clearly, those with nicotine seem to be the difference. And our biggest problem in Canada is that we only have them manufactured to good manufacturing practices, not to GCP, which means they can't have an indication for cessation. And there's always those risks with flavors that we have, long term, we have no good data on. Anything you want to add here to?
Yeah, and to your point, it is uncomfortable to recommend vaping as a means to quit smoking, and then to not be able to give any guidance around which products, which dose. It's uncomfortable.
It's uncomfortable. And again, when you take a look at it, this also compares nicotine to all the other medications. Clearly, obviously, Verticalin comes out on top, and combination nicotine replacement. But nicotine e-cigarettes are clearly, in the UK at least, a viable option. If people are going to use it, they need to switch completely, and you can see this in lower risk nicotine use guidelines or Project Vector. Switch completely, no dual use, and understanding that the long-term health effects are known, but use it for as long as you need to prevent a relapse back to tobacco. Follow all the appropriate instructions and dispose them appropriately. And here you can get the guidelines over there. They'll be in the handout. And again, reduce nicotine in cigarettes and e-cigarette use. This, we don't have that anymore, so we're not going to spend it. But clearly, with this new settlement, my wish was that all the tobacco companies agreed to stop selling cigarettes which have more than 0.4 milligrams per gram of tobacco, so that really you'll see a big impact, and then that would make cigarettes non-addictive, and clearly, but that's not what's going to happen, unfortunately. We're going to continue to see the harm from cigarettes. I'm not going to go into that. We've talked about this, just in interest of time. Dual use, same thing. Quit both. Not recommended as a long-term continuation. I get people to transition over to one or the other and then quit. What about you, Milan? Have you done anything like that?
I mean, exactly that. When we see people who are using both products, we are encouraging them to move to the use of the less harmful one, which is vaping only, unless, of course, they can quit everything together. Individual choice.
Yeah. Okay. I mean, I think we've really got a lot of data here that you can look at some of the papers that are there, but we're not, just in the interest of time, where the social pressures again is out there in terms of people smoke when they can and vape when they can, and we really need to denormalize and those kinds of ideas, and just treat it like a tobacco product. Smoke it outdoors, don't use it, and that's it. Okay, so moving right along, health effects. I just in the last minute. Third and hands of effects of vaping. I don't think there are, but that's what most of us don't think there are. But again, fetal effect is that of nicotine, and clearly nicotine is problematic. But again, is the woman willing to switch over to nicotine replacement? Okay, we don't have time to go over all of these things, but they are there for you. And I'll just take the last one around grabba. Grabba is a tobacco leaf often used in Caribbean countries as a way to smoke cannabis. And it is a tobacco plant, and people can get dependent on it. So you do need to manage that. And typically what I'm helping people when they're quitting cannabis is to try to get it without the grabba, and that helps them quit both the grabba and the cannabis because they're getting into trouble with it. Yeah, so that's that. And yeah, so again, there's Leslie's talking about people using Zonic versus gum, whatever people can tolerate. And I think the oral health impacts are really about tobacco. It's not so much about nicotine. Yeah, and there are people talking about these anecdotal issues of switching for chewing tobacco, and I think it really does make sense. All right, we have a lot of questions. I don't think we're going to be able to get to everyone because it's already 1 o'clock. I want to thank you, Milan, for your contributions and your wisdom as well. And I don't know if any other points, Rachel. Otherwise, we will bring it to a close.
No, yeah,
Gotta run back to the
thank
clinic.
you both. Thank you, Dr. Khara, and thank you, Dr. Selby. It really was so engageful, and as you can see, everyone in the chat agrees as well. And you're right, we don't have time for questions, but we have both their emails on the screen. So if anyone does have some questions or wants to reach out about anything that was addressed today, you can do so. We also be sharing a copy of the slides to everyone attended as well. But if at this point, if anyone needs to leave, feel free to. I'm just gonna keep going with some housekeeping items, but thank you everyone for joining. And thank you, Dr. Selby, and thank you, Dr. Khara.
And Rachel, can you keep a copy of the chat questions? Because there are some things that we can push over to the youth project and get some answers back to people.
Yeah, I can do that for sure.
Okay.
Yeah.
All right, Milan, good to see you. Thank
Good to
you.
see you guys.
Thank you.
Now. Okay,
Bye for
bye
now.
everybody. Have a great
Bye,
afternoon.
everyone.
Bye.
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 So just for those who are still on, a couple of reminders that you will have a week to complete the post-learning assessment and evaluation that will be sent out to everyone by end of day tomorrow. And our next Teach Educational round is going to be a women-specific smoking cessation smartphone app, results from an acceptability and feasibility study. And it'll take place on December 4th. So we'll have registration opening for that as well soon. And just a reminder that if you missed part of today's presentation and want to view it again, or you just want to view another previous Teach Educational rounds, we do have a list of archived webinars on our website. But for now, thank you everyone for joining. That concludes our webinar, our Vaping Q&A 3.0, and I hope everyone has a good day. Thanks.